Welcome to Brief Interventions and Brief Therapies for Substance Abuse, Tip 34, brought to you by allceus.com. Some of the benefits to brief therapy include a reduced no-show rate, increased treatment engagement, increased treatment compliance, both psychoeducational treatment and medication treatment compliance, reduced aggression and isolation from other patients, and it can also provide an interim for clients on waiting lists for a more intensive treatment. The objectives for brief interventions are geared to extract at least one measurable change in the client's behavior, and they can focus on things such as time management, expanding a sober support system, developing clean, sober social skills, like what do you do when you're not drinking and drugging to have fun? What do you enjoy? How do you have fun? How do you interact with other people when you're not under the influence? Vocational issues. This may include going to vocational rehabilitation, job placement work, looking for a new job, additional training, etc. Support group attendance. You can work on setting a certain number of support groups the person has to attend each week. Forgiveness and acceptance. Now this is one of your more vague goals for brief interventions, but it works on having the person address the resentments that they hold and decide whether they're going to let them go or do something about them. And staying in the here and now. That means not worrying about the past or the future, feeling regret over the past, but focusing on the here and now. How is this affecting me now? What can I do about it now? The basic goal of any intervention is to lower the likelihood of damage that could result from continued use of substances. So we're not necessarily just targeting the use of substances, but we want to prevent further damage in all other aspects of that person's life as well. We can do this using a system called frames. F is for feedback. Provide them objective feedback of what you see. What does your assessment tell you? What are the ugly realities they may not be ready to look at? But also, and this is what we often forget, what are the good things? What are the strengths? What are the positives you see? Because the last one, self-efficacy, is going to be difficult if you've beaten them down and only pointed out the negative to now. R is for responsibility. Put the responsibility for change squarely on the shoulders of the client. It's their responsibility to show up. You can help them, but it's their responsibility to do the next right thing. Provide them advice. And that makes a lot of counselors kind of cringe, but it was the only A word they could come up with, I think. We have knowledge. I prefer the word education. Provide them knowledge about other coping skills, about other options that are available to help them solve their problems, but provide them a menu. M is for menu of options to choose from. So you're not telling him, John, you've got problem X, you need to do this to fix it. You're working with John, identifying what problem X is, providing advice or information about the different options that are available to him to deal with X, and letting him choose. This all has to be done with empathy. Provide empathic understanding of how hard it is to make these choices and make these changes and basically start over again. But emphasize that John can do it. He has the strength. He has the tools. And what tools he doesn't have right now, you can help him develop because he has the ability to do this. There are 5 steps for a brief intervention. The first one is introducing the issue in the context of client health. Present it as a broad issue. It's not just a bad thing that you're doing. Look at how it's impacting your health, how it's impacting your relationships, your social health, your general wellness and well-being and happiness. Then you want to screen, evaluate, and assess. Remember, screening only determines whether a person needs further in-depth assessment and evaluation. Provide them feedback. You can do this after a screening, especially if you're going to refer them for further evaluation. Provide them feedback about what you saw and why you think it warrants further evaluation. Talk about change and setting goals. My guess is I rarely have had a client who was voluntary come into my office and say, I have no problems. If they're in my office, then there is a problem. They may not be ready to work on substance abuse, but they may be ready to work on something. So, at this point, talk about change and goal setting in terms of what they're motivated to change right then. Remember, this was just screening. We haven't done an assessment or a treatment plan, but give them something to focus on, something to work on, something that will provide them a measurable success between now and your next appointment. And then summarize and reach closure with the client. This is what I saw, this is what we discussed, this is the next course of action. The core assessment areas need to look at current and historical use patterns and consequences, their health status, and how that interacts with current and historical use patterns and consequences. Information about education and employment. How much schooling do they have? Do they like school? Do they hate school? What are they good at? Some of this can be done in vocational rehabilitation or with a vocational counselor, but it's a good idea to help them at this particular juncture identify some of their strengths. What are they good at? What can they do? What gives their life meaning? What are their support mechanisms? Do they have friends that they can rely on? Do they have close family? What do they do for emotional and social support? Look at their strengths and their situational advantages. Some clients may be in the position where they're able to take 30 days and go into residential treatment, whereas others might not. Each client will come with their own unique set of strengths. Even things that they have used, for example, their ingenuity, is often used in addiction to get the wrong things. But you can point that out as a strength. If you use it for good and not evil, it can help you stay clean and sober. Be resourceful. You've been resourceful in the past. When you're doing your assessment, you're going to find out about their family history and their background and their trauma history. Again, I can't think of a voluntary client that's come through my office that hasn't discussed at least some trauma or major event or some crap in their life, but they got through it. And that is what I will focus on. How did you get through it? You pulled yourself up by your bootstraps. You did it then, you can do it now. You want to look at previous treatment. A lot of people have been in previous treatment. And if they haven't, you can say, all right, there are a lot of different options. Is there anything at this point that, you just don't feel comfortable with? And some things that may come off the top of their head is medication or electroconvulsive therapy or something like that. A lot of people, especially if they're being evaluated for a residential program, have misconceptions. They think of One Flew Over the Cuckoo's Nest. And that's not how it is. That's not how it is at all. So we need to bring this to the forefront and help them understand what to expect in therapy. But getting back to previous treatment, if they've been in treatment before, what worked and what didn't? I sure don't want to beat my head into the wall and do something that you've tried 4 times before and has never worked. Or that you've been told to do 4 times before, but you've never done. So what will you do? And what's worked for you? And we'll work from there. And then, of course, look at family history. who in the family has addictions, who in the family has depression, anxiety, what was the family life like growing up, how did people cope, and you may not even need to address addiction right away, but how did mom cope when things got tough? What did your mom do? What did your dad do? Etc. In all this, and most people that are getting continuing education have already been trained in active listening, but I will put it out there anyway. You need to listen to what's said, paraphrase it in your own words, and then test the accuracy of what you heard. Generally, you're not going to just parrot back to them exactly what you said. If John says, it was really rough when I was growing up, you're not going to turn around and say, well, John, I hear you saying it was really rough when you were growing up. He's going to look at you like you've got three heads. That's condescending and annoying. So hear what he says, but also look at the nonverbals and figure out how it relates to everything else and come up with your own words to paraphrase what he's telling you. It was rough going up, but what does that mean to John? Now, depending on your person's stage of change, you're going to use different treatment interventions. For people in pre-contemplation, they don't have a problem and nobody can tell them they have a problem. So, okay, fine. You need to provide them information linking their problems with their substance abuse. Plant the little seed. They may be far enough in denial that they're not going to admit to those linkages yet. But plant the seed, and they'll think about it, and they'll kind of chew on it for a little while. Provide them education. Motivational interviewing. List 5 ways substance use has impacted your health, your family, your work product, your mental status, the way you think, your emotions, etc. Get family and peer commentaries specifically about the client. What does your mom say? Or if mom's there, ask mom, how do you feel about what's going on? Or how have you seen John's behavior change since he started using? Clients in contemplation know they've got a problem, or at least they're willing to think about that. So help them explore feelings of ambivalence and the conflicts between their substance abuse and their personal values. This ambivalence is, maybe I've got a problem, but then I see Jim, Jane, and Sally all doing the same thing, and nobody says they've got a problem. So there's a lot of ambivalence. They realize that it's starting to become unmanageable, but they don't want to admit it yet. Help them increase their awareness of the consequences of continued abuse and the benefits of decreasing or stopping use. This can be phrased in terms that are meaningful to the client. Now, it's a bit manipulative, but again, you look at what are their goals. If Sally comes to you and she's an alcoholic, but she's also got comorbid bulimia, help her see how her drinking impacts her weight. She needs to decrease or stop use. She also needs to develop some other coping skills. You need to help her see how drinking impacts her finances. It impacts her relationships. Identify things that are meaningful to that client to use as points. A client in preparation knows they've got a problem, but they're not ready to do anything yet. They're just sitting on the fence. So strengthen their commitment. Identify the benefits of treatment. Identify and address their fears and apprehensions about treatment. They may be worried they won't be able to see their family for 30 days. Or once they walk into those doors, the doors are locked and they can't get back out. Or who knows? There's a myriad of different things that could happen. It may not even have to do with treatment. It may be if I go into treatment, then people are going to find out I've got an addiction and I'm going to lose my job or I'm going to lose my insurance. Ask them. Help allay those fears as much as you can. Give the client a list of options for treatment. Okay, if you're not ready for this, what about Alcoholics Anonymous or something else? And help the client plan how to go about seeking treatment. Don't say, well, you might try an AA meeting and leave it at that. The client's going to be like, what do I do, look it up in the phone book? Or provide them a list of numbers, the website where they can look up meeting times, information about maybe the professionals group if that happens to fit their profile. Help them identify what they need to do, what's the next right thing, and how to know if they need to ramp up their treatment. People who are in action are ready to do it. So help them execute an action plan. Help them identify and address obstacles to following through. What might cause you to drop out of treatment? What things are you most worried about while you're in treatment? If you can address those when they come in, then it's less likely that they're going to interfere 2 or 3 weeks down the road. And provide immediately useful tools. When you start feeling anxious, you need to do X, and that'll depend on the client. They may need to go see a counselor. They may need to start reading in their big book. They may need to read in their Bible. They may need to go on a walk. Talk to them. Say, what helps you when you start feeling anxious? What helps you de-escalate? If they don't know, then they're probably going to come see their counselor. And the two of you can work together to figure out a bunch of things, not just one, but several things that they might try when they start feeling anxious. Work on skills to maintain sobriety. Relapse prevention plans. Identifying high-risk situations and how to deal with them. And acknowledge the client's feelings and experiences as a normal part of recovery. The good, the bad, and the ugly. Each day is going to be different. You're going to have that pink cloud come in there, and you need to prepare them for their pink cloud. That feeling that they've got it licked. They know what to do next, and they are recovered. Prepare them for that. Because the fall from that cloud is really hard if they're not braced for it, and if their sponsor is not there to really help them temper their self-congratulations. And in maintenance, people need to be reassured that they're doing the next right thing, that this is how they're supposed to feel. They need to be able to bounce ideas off others and evaluate their present actions and regularly redefine their long-term sobriety plans. Life changes. Their plans are going to change. And it's helpful if they have someone they can bounce those ideas off of. Essential knowledge and skills for brief therapy includes an overall attitude of understanding and acceptance, the ability to actively listen and help clients explore and resolve ambivalence in order to move them to action, the ability to focus on intermediate goals, not just the prize at the end of the road, but those steps along the way, and to rejoice in each small success, and a working knowledge of the stages of change. Brief therapies tend to be problem-focused or solution-focused. They target the symptom and not what's behind it. So if you're drinking right now, brief therapy is not going to focus on why you started drinking and how your family impacts all that and all the underlying stuff. They're going to target the symptom. You're abusing alcohol, how do we stop that? There are clearly defined goals related to a specific behavior. You are going to stay clean for a week. You are going to do urine tests twice this week, etc. The goals are understandable to both the client and the clinician and agreeable to both. If the client's not on board, you might as well hang it up. They do produce immediate results. It's one of the beauties of looking at short-term intermediate goals. You're providing rapid success and rapid reinforcement. And you're providing them something useful. When you start feeling stressed out, you call your sponsor. A to B. It's a useful tool. Ta-da. It may not be the panacea, but it's an alternative to using or to feeling like they're going to just explode. Brief therapies provide rapid establishment of a working relationship. If you're working with somebody and you're actively listening to them and you're hearing their goals and you're providing them hope that there can be rapid change and setting them up for rapid success, you're going to work well together. I mean, if somebody came up to you and said, let's work together, I heard all these things and where you want to go, and we're going to do these boom, 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 and we can do it. You'd be following them around like a puppy dog. Okay, tell me how. It's highly active, empathic, and sometimes directive. Now again, we don't want to tell them how to do everything all the time. We will, in the beginning, probably need to educate them to help them develop new skills. But remember that menu. We provide them with a menu of skills so they can choose from the chicken, the fish, or the beef when they start getting stressed out. And we're not the one deciding it. We're providing them options. Everybody needs options. The responsibility for change is placed clearly on the client. You can lead a horse to water, you can't force them to drink. A client has to change for it to be successful. All those things you've heard over and over again. But what it comes down to is they have to do it. They have to do the next right thing because you're not going to be sitting on their little shoulder 24 hours a day. Experiences enhance self-efficacy and confidence that change is possible. Again, those small short-term goals that prove to them that despite what they were told when they were growing up or whatever, they are a success and they can do it. Termination is discussed from the beginning. You provide these intermediate goals and intermediate successes, but at the beginning, you have to know where these goals are going. You don't just walk up a stairwell not knowing where it's going to go. Likewise, you have that ultimate goal out there. Termination is going to be when you've achieved this goal. So we need to talk about that from the very beginning so we know where to go. Otherwise, we're just going to sit there spinning our wheels. And outcomes are measurable. Person stayed clean and sober for X number of days. The person has remained medication compliant for X number of days. The person has attended so many meetings. The person has done whatever. There are clearly observable goals. But brief isn't appropriate for everybody. If someone is in crisis or has acute psychosis, intoxication, things like that going on, if they're not clear-headed and they don't have a good support system, brief's not appropriate. If they've got active dual diagnosis issues. Now there are a lot of people with dual diagnosis issues who do really well with brief therapy as long as their co-occurring mental disorder is well controlled. But you don't want somebody in the throes of a major manic episode and then try to use brief interventions. It's not going to work. You need someone who's able to focus and concentrate. The range and severity of presenting problems. Someone who has PTSD, is homeless, has been spending $1,000 a week on crack, and has hepatitis, probably not going to be your best candidate for brief therapy. They've just got too much going on. Now, yes, you can provide some brief interventions and some hope and help and all that kind of stuff, but they're going to need a whole lot more than just brief therapy. The duration of the substance dependence. If it's been going on for 15 years, you're not going to have the foundation to work with that you might need for brief therapy, and you're not going to have the sober social support system out there. If they've been actively substance dependent for 15 years, most of their social support, if not all, are probably using and abusing. You need to look at previous treatment or attempts at recovery. How did they end? If there was successful completion and things were wonderful, then great. If the person discharged and tried to commit suicide a week later, not such a good candidate. And the level of client motivation. Now, this is kind of touchy because, remember, we've said before that clients' motivation will be different for different problems. If you have an involuntary client who is motivated to get rid of you, then they will be treatment compliant. And you can use some brief interventions to help them achieve some of their goals. Does that address their substance abuse? Well, maybe not. But if you use competing responses where they can't do X, they can't abuse substances if they're doing whatever other behavior, that inadvertently will help their substance use. I had a client whose son was starting to have problems in school and act out and stuff, and this client abused marijuana. And he really was concerned about his son, genuinely concerned. And so we talked about what, might help his son out, and he said he felt disconnected, etc. Well, long story short, the client started going out and playing basketball with his son every afternoon after the boy finished his homework. That was the contingency. If the boy finished his homework, Dad would go out and play basketball with him. Well, Dad couldn't smoke, at least not smoke marijuana, while he was out playing basketball with Junior. And that was actually Dad's high-risk time, was after work. So Junior came home, did his homework before Dad got home. They ate dinner, and they both went out and played basketball. So you can use the client's goals to not only help them achieve their goals, but also help them stay clean and sober, even if that's not one of their pressing or highly motivated issues. The clarity of the client's short and long-term goals. If they don't know what they want and where they want to be and what they want to do, if they're just kind of, you're not going to be able to form an incremental plan, because you can't form an incremental plan to, They need to know where they want to go, and if they don't, then they're probably still in a fog, and we need to wait till that fog starts to lift a bit. The client's belief in the value of brief therapy. Some people really, really feel that it's vitally important to talk about their mother, or what happened when they were a child, and really go in depth into all that stuff in order to evidence any sort of improvement. And if your client believes that, then brief therapy is probably not going to be effective, because they're not going to want it to work. And the numbers of clients needing treatment. Brief therapy is extremely rapid. You can provide a lot of very positive help to people in a relatively short period of time. So if you've got high caseloads, brief therapy might be something to look at. Criteria for longer-term treatment is a failure of previous shorter treatment, multiple concurrent problems, severe substance abuse, acute issues, cognitive inability to focus, long-term history of relapse, unsuccessful treatment episodes, low social support, and serious consequences related to relapse, such as suicide attempts or health problems. In brief therapy, when you conduct an assessment, you want to look at current use patterns, their history, their consequences, major medical problems, education and employment, their available support mechanisms, their strengths, their previous history of treatment, and their family history of substance abuse. During the opening session, produce rapid engagement. Identify, focus on, and prioritize problems. Work with the client to develop possible solutions. Negotiate the plan. Elicit client concerns and solutions to those concerns. Understand the client's expectations. Explain the structural framework of brief therapy and make referrals as needed. Now remember, you need to make referrals to help the client address some of their biopsychosocial needs and or if they do not accept the brief therapy format. When it comes to maintenance, you want to educate the client about the chronic, relapsing nature of substance abuse disorders. It's with them for life, and they're always going to need to be vigilant. Help them develop a list of circumstances that require a return to treatment. Develop a list of relapse triggers and solutions. And review problems that emerged but were not addressed in treatment, and help the client develop a plan for addressing them in the future. Develop strategies for identifying and coping with high-risk situations, such as family gatherings, holidays, certain work situations. Teach the client how to capitalize on personal strengths and emphasize client self-sufficiency. They can do it. Finally, develop a plan for future support, including mutual self-help groups, family support, and community support. Now, what's out there? Mutual support groups. AA, NA, whatever's available in your community. There are also some groups that are available through churches. Family support. Broadly define family here. It may not be the client's family of origin, those to whom he or she is genetically related. Who do they rely on? Who is their family? And community support. Where can they go in their community for support for different things, not just substance abuse, but if they start to get depressed or in order to find just stress relief. When you terminate with clients, you want to leave on good terms. Give them hope for continued change and leave the door open. Elicit a commitment from them to try to follow through with what has been learned in treatment. Review the positive outcomes that they can expect and that they have already achieved. Identify possible pitfalls and develop solutions. And review the early indicators of relapse. There are certain techniques that can be used in brief therapy. One is cognitive behavioral. CBT assumes that substance abusers are deficient in coping skills or choose not to use those that they have or are inhibited or unable to do so for some reason. CBT helps clients recognize situations in which they're likely to use, those high-risk situations. It helps them find ways of avoiding those situations and helps them cope more effectively if they are in those situations. Core elements include a functional analysis. Identify the antecedents and consequences of substance use behavior. The antecedents are what happens before the person uses, what triggers their use, and what are the consequences, and what things maintain the substance abuse. What are the rewards? If something happens and then they use, there's some sort of a reward that makes it so when that thing happens again, they're likely to use again. Through this functional analysis, the person can identify their triggers and develop more appropriate coping skills. Develop a list of high-risk situations and practice those situations in relapse prevention groups. CBT is generally not appropriate with people with psychotic or bipolar disorders who are not stabilized on medication. People who have no stable living arrangements and who are not medically stable. All three of these categories of people probably need to be in pretty highly intensive supervised situation in order to help them stay clean and sober. The initial session for behavioral techniques explores the reason the client is seeking treatment, the extent to which the motivation for treatment is intrinsic versus influenced by external factors, Department of Children and Families, legal factors, the spouse, the wife, or the mother, whatever. Areas of concern that the client and significant others may have about the substance use. Situations in which the person drinks or uses excessively, and the consequences. When using cognitive techniques, the cognitive therapy works under the assumption that the client can be educated to approach his problems rationally. There are three major steps. First, establish rapport. Understand how the client thinks about his life circumstances and how those thoughts relate to the problematic feelings and behavior. What's the client's perception of the world? Ask the client about the cognitive model. This is how I think you see the world and how I think you perceive things. Am I right? Does this fit? Ask the client to describe a recent event that has triggered some negative feelings as a way of illustrating the cognitive therapy process. So ask them to talk about something that has elicited negative feelings, and then use cognitive techniques to show them how they could have approached the situation rationally. Brief strategic interactional therapies focus on the individual's strengths, but the relationship to the therapist is essential. So if you don't have a really good working relationship with this person, you're not going to want to start out with brief strategic. Interventions are based on client self-determination, with the community as a whole serving as a resource rather than an obstacle. It's not the cause of their problems. It's going to be a resource for their recovery. It defines situations that contribute to substance abuse in terms meaningful to the client. It helps identify steps needed to end their substance abuse and heal the family system so it can support change. It helps maintain behaviors that will help control substance use, and it responds to situations in which the client has relapsed. When getting ready to terminate in this situation, you want to prepare the client to maintain positive change through difficult times, to identify potential stressors and challenges, prepare the client for changes to the environment, and ask him to look into the future at the end of treatment and describe where he intends to be 6 months from now or a year from now. Brief Humanistic and Existential Therapy emphasize understanding the human experience, focusing on the client rather than the symptom. Psychological problems are the result of inhibited abilities to make authentic, meaningful, and self-directed choices about how to live. In the initial session here, you want to build an alliance, develop therapeutic rapport, and create a climate of mutual respect. Emphasize the client's freedom of choice and potential for meaningful change, and articulate the expectations and goals of therapy. This is more the Rogerian approach that most of us were trained in school. Brief psychodynamic therapy enables the client to examine stuff from their past, which leads to a desire to abuse substances. People who might be appropriate for brief psychodynamic therapy are those who have coexisting psychopathology with their substance abuse disorder. Those who don't need or who have completed inpatient hospitalization or detox. So they have to be clear-headed and able to focus and concentrate on treatment. Those whose recovery is stable. You don't want to take somebody who is unstable in their mental health or their substance abuse recovery and start really delving in and exploring stuff that's just asking to precipitate a crisis. And it's not appropriate for those who have organic brain damage or other limitations due to their mental capacity. In this approach, you want to work with the client's perceptions of reality. Ask questions and sidestep defenses rather than confronting them. Demonstrate the denial defense while interacting with the client to show her how it works. So this defense of denial, I don't have a problem, you can't tell me how I have a problem. You demonstrate that to them with something that they can clearly see. You deny that it exists, and they can see how denial really works. Another approach is brief family therapy. It asserts that interactions with the family sets the patterns and dynamics for problems with substances in these particular patients. It also asserts that family member interactions can either perpetuate or help resolve the problem. Family therapy offers an opportunity to focus on the expectation of change within the family, to safely test new patterns of behavior, to teach how a family system supports and maintains needed roles, elicit the strengths of every family member, and explore the meaning of substance abuse within the family. Family therapy approaches the problem as a systemic problem, not the individual patient's problem. There is something in the interactions that's supporting that person in being ill, in being the identified patient. What is the benefit to the family of that person being the identified patient? What would happen if that person started to get better to the power dynamics and the role functions in the family? In the initial session, clarify the nature of the problem and identify the family's goals with open-ended questions such as, what is your goal in coming here? Educate the family about what is needed to participate effectively. Understand key biosocial issues related to substance abuse. Provide feedback to the family on what was said, demonstrating whose goals are similar and whose are different. This will start showing you your alliances. And prioritize directions for change, or if the direction is sufficiently clear, start work. When the family as a whole can benefit from teaching and communication to better understand some aspect of the substance abuse disorder, family therapy can be very helpful. If the family as a whole is not willing to participate, it's not going to be very effective. therapy. I'm a big proponent of group therapy. Groups can help reduce denial, help people process ambivalence, and facilitate acceptance of a diagnosis of alcohol abuse, substance abuse. Groups can increase motivation for sobriety and other changes and help treat the emotional conditions that often accompany drinking and drug using. Groups increase the capacity to recognize, anticipate, and cope with situations. And they also provide a very safe place to rehearse real-life situations. Think of your group as a microcosm of the world, quote, out there. Things are going to come up. People are going to get into disagreements. There are going to be issues in your group. They're human beings. They're interacting. If they can safely learn to interact and communicate, express their feelings, cope with things, have positive relationships, and have positive terminations in group, they're going to be much better off. And groups also meet the intense need of substance-dependent clients for social acceptance and support. In the initial session, the locus of control for the group is clarified. Why are we here? What is the operation of the group? How does this group function? And who's in charge? Clients explore whether they believe they have the ability to choose effective actions. Do you have the ability to choose, or does life just thrust upon you? The goals for the group are clarified. You establish a safe, warm, supportive environment, rules to increase safety, and help group members establish connections with each other, pointing out common concerns and problems. Remember I said before, it's like a microcosm of the community, but also maybe of their family. Look for ways that they are expressing transference reactions towards maybe authority figures in their group, etc. In summary, brief therapy is a cost-effective technique that can enhance treatment compliance, improve outcomes, and reduce cost per patient expenses.